Welcome, everyone. Today, we are going to take a really deep dive into the critical, and I mean critical, role of the anesthesiologist in this era of robotic surgery. Our goal here is to take all these complex physiological principles and transform them into clear, actionable strategies you can use in your clinical practice tomorrow.
Okay, so here's our roadmap. We're going to build our expertise from the ground up. We'll start by understanding the landscape, what makes robotic surgery so different. Then we'll get into the intense physiological changes we have to manage. After that, we'll cover specific practical guidelines for both pelvic and thoracic procedures before moving into those crucial crisis protocols. And finally, we'll tie it all together with some high-level strategic pillars for our practice. Let's get into it. All right, first things first, we have to establish why robot-assisted surgery isn't just a slightly fancier version of laparoscopy. It is a fundamental revolution in how our entire workspace is organized and how we interact with our patients.
Now, this is a fantastic comparison. For the surgeon, the benefits are just incredible, right? They go from a flat 2D image to a high-def 3D view. Their natural hand tremors are filtered out, and the robot gives them a range of motion that's better than the human wrist. But, and this is a huge but for us, look at that last row, the physical footprint. While the surgeon is immersed in this amazing virtual world, our world in the OR changes dramatically. That large, bulky robot becomes the single biggest factor altering our workflow and our access to the patient.
So this really gets to the heart of the matter for us. What is the so what? Well, the robot essentially physically isolates you from the patient. This creates what I like to call the triple challenge. First, there's access. Your ability to get to the airway, to IV lines, to anything is severely limited once that robot is docked. Second is time. These procedures can be long, really long, due to complex docking sequences and meticulous dissections. And third, there's positioning. Many of these cases demand extreme patient positions, like steep Trendelenburg, which unleashes a whole cascade of physiological consequences we have to manage.
This slide right here illustrates our primary number one challenge. You have to remember, a robotic arm is not like a human assistant's hand. It's fixed, it's rigid, it cannot adapt or move if the patient moves. A cough, a buck on the tube, any movement at all could lead to a catastrophic tear of a vessel or organ. This is precisely why a deep neuromuscular blockade, monitored quantitatively to a train of 4 count of 0, isn't just a suggestion or a good idea, it is an absolute non-negotiable mandate for patient safety in robotic surgery.
Think of this checklist as our first line of defense. Our role as the gatekeeper for patient safety starts long before the patient enters the OR. We have to be able to identify patients whose underlying conditions could be dangerously worsened by the huge physiological trespass of robotic surgery. For example, a patient with glaucoma already has high intraocular pressure. Putting them in steep Trendelenburg could be devastating. The same goes for someone with elevated ICP. Knowing these contraindications, both absolute and relative, is how we protect our patients before we even begin.
Now, building on that, let's really get into the weeds and dissect the physiological storm. This is what happens when we combine CO2 pneumoperitoneum with that steep Trendelenburg position, a combination that is the hallmark of almost every pelvic robotic surgery. This right here is the mental model you need to keep in your head throughout the entire case. You have two powerful opposing forces at play. On one hand, the extreme head-down position is causing a massive venous return from the legs and gut. It's effectively giving the patient a huge, continuous fluid bolus, driving up preload. But at the exact same time, the 12 to 15 millimeters of mercury of pressure from the pneumoperitoneum is compressing the great vessels and acting like a giant clamp on the aorta, massively increasing afterload. The heart is caught right in the middle of this battle. And this table summarizes that multi-system assault we're managing. It's a cascade of effects across the entire body. Look at the cardiovascular system. Pressures like mean arterial pressure and systemic vascular resistance are soaring, while the actual cardiac output often falls. Then look at the respiratory system. The diaphragm gets pushed up towards the head, which increases airway pressures and resistance while literally shrinking our functional lung volume. And critically, you see the same pattern in the nervous and ocular systems. Pressures are rising, creating a significant and dangerous risk. Okay, let's put some numbers to this. These are from actual clinical studies. Look at that jump in afterload. The systemic vascular resistance skyrockets from around 1,400 to over 2,000. That is the clamp effect we were talking about. And notice, even though the Trendelenburg position is jacking up the CVP and preload,
that massive increase in afterload is so powerful that it ultimately leads to a slight but very significant decrease in cardiac output. Basically, our patient's heart is working much, much harder to pump less blood against an enormous amount of resistance. So this is the crucial takeaway for our ventilator management. Our strategy has to actively fight back against these mechanical forces. The diaphragm is being shoved up into the chest, literally shrinking the space available for our lungs. This leads to atelectasis, especially in the dependent areas, and a VQ mismatch. So the clinical command here is crystal clear. We must adopt a lung protective strategy. That means low tidal volumes based on ideal, not actual body weight. It means applying an appropriate amount of PEEP to help stent open those collapsing alveoli. And sometimes it means accepting a slightly higher CO2 level, what we call permissive hypercapnia, as long as the patient's pH stays above 7.25. It's a trade-off to avoid dangerously high airway pressures and ventilator-induced lung injury.
Now, the pressure doesn't just stop at the chest, and this is so important. We have to be incredibly vigilant about these hidden dangers. The same forces that are affecting the heart and lungs are also impeding venous drainage from the head. This directly increases intracranial pressure. But critically, it also increases intraocular pressure. If this pressure stays elevated for a prolonged period, it can reduce perfusion to the optic nerve, leading to ischemic optic neuropathy and, in the worst-case scenarios, permanent irreversible vision loss. This leads us to a really critical decision point in our anesthetic plan. Knowing these serious risks to the brain and the eyes from all this pressure, how do we choose our anesthetic agents to best mitigate this danger? Is a standard volatile-based anesthetic the right choice, or should we be thinking about a different technique entirely? Well, the evidence here is actually quite compelling. Volatile anesthetics are known vasodilators, and that includes cerebral vasodilation. This can actually make the increase in intracranial pressure worse. In stark contrast, total intravenous anesthesia, or TIVA using propofol, is demonstrably better at mitigating these dangerous pressure increases in both the eye and the brain. So, for any prolonged robotic case, and especially one that involves steep Trendelenburg, TIVA should be very strongly considered the preferred technique for neuro-ocular protection. Okay, so with all those core physiological principles under our belt, let's start applying them. We'll move into our first specialty guideline, focusing on those really common and challenging procedures in the pelvis, like robotic prostatectomies and hysterectomies. This slide brilliantly illustrates the two dominant architectures you'll see in the robotic space. On the left, you've got the classic layout for the Da Vinci system. See how that large, single-cart design creates a pretty significant physical barrier between us and the patient? Now, on the right is the Versius system, which uses smaller, modular arms on separate platforms. As you can see, each of these designs is going to present very different challenges and opportunities for our access and our setup. Understanding these technical differences is absolutely key to planning your day. With the Da Vinci, you have to plan for a rigid no-go zone around that central cart, and that often means your direct access to the patient's head is completely blocked. The modularity of the Versius system can allow for more flexible positioning of the arms, which can potentially preserve a corridor for you to get to the patient. Your entire pre-docking plan, where you put your machine, your drug cart, your IV poles, has to be tailored to the specific system you're using. Before a single robotic arm moves toward that patient, this 4-point check must be completed. Think of it as your pre-flight checklist. It's not optional. First, are all of your lines, your airway, your IVs, your arterial line, not just secure, but actually accessible for the entire case? Second, is every single pressure point padded? Are the eyes taped and protected? Third, is every one of your monitors on, functioning, and visible from your station? And finally, a clear verbal confirmation with the entire team. This is absolutely non-negotiable. Okay, a huge part of modern anesthetic practice is integrating with enhanced recovery after surgery or RAS protocols. A really robust regional plan is essential if you want to manage postoperative pain effectively while minimizing opioids. This table gives us our primary options. A TAP block is great for the somatic pain from the anterior abdominal wall port sites. But if you need broader coverage, maybe some visceral analgesia, you'll want to consider a QL or an ESP block. And of course, a thoracic epidural still remains the gold standard for potent, reliable analgesia when it's indicated. All right, let's switch gears completely now and pivot to the unique challenges of the thoracic cavity. In here, everything changes. We're dealing with lung isolation and CO2 insufflation directly into the chest, a condition we call a capnothorax, which creates a very, very different kind of physiological storm. So, effective lung isolation is really the cornerstone of robotic thoracic surgery. One lung ventilation, or OLV, is absolutely necessary. You have to deflate the operative lung to create the physical space the robot needs to move around and work inside that very confined thoracic cavity.
But here's the thing, not every patient can tolerate having 50% of their lung function taken away, even for a short time. This table outlines the critical conditions that might make a patient unsuitable for robotic thoracic surgery. An inability to ventilate on one lung is, of course, an absolute contraindication. But conditions like severe pulmonary hypertension or pre-existing hypoxemia on two lungs, those require extremely careful consideration and discussion with the surgical team.
So our management plan for robotic-assisted thoracic surgery, or RATS, is really multifaceted. Airway management is paramount, and double-lumen tubes confirmed with a bronchoscope are the standard of care. Our ventilation strategy becomes even more protective here. Notice the tidal volumes drop to 4 to 6 milliliters per kilogram. And you must anticipate the hemodynamic consequences of that capnothorax. That insufflated CO2 in the chest will compress the great vessels, reducing venous return and cardiac output. This makes invasive arterial monitoring absolutely essential, and you should expect hypotension the moment they turn on the gas. Okay, let's talk about the what-if scenarios, because things can go wrong very quickly. And with our limited access to the patient, having a clear, well-rehearsed plan is absolutely critical. Knowing these protocols inside and out is what transforms academic knowledge into a life-saving cognitive aid in a crisis. A CO2 embolism is thankfully rare, but it is a truly catastrophic event. The classic signs you're looking for are a sudden precipitous drop in end-tidal CO2, profound hypotension, and cyanosis. If you suspect it, these 6 steps must be initiated immediately. Alert the entire room, tell the surgeon to stop the gas source, flood the patient with 100% oxygen, and get them into Durant's maneuver, left side down, head down, to try and trap that air in the right ventricle. This is a true anesthetic emergency, and you have to act fast. In a crisis like a cardiac arrest or a massive hemorrhage, you have to get to the patient. And that means you have to get that robot out of the way, and you have to do it fast. Every single person on the team must know their specific role in this sequence. The anesthesiologist makes the call, loud and clear. The surgeon gets the instruments out. The tableside assistant undocks the machine. This entire process should be practiced and timed during simulations. Your goal should be to regain full, unimpeded patient access in under 60 seconds. This right here is our shield. You know, prevention is always better than reaction, and comprehensive multi-parameter monitoring is what allows us to see those subtle changes and intervene before a small problem becomes a huge crisis. For robotic surgery, this goes way beyond the basics. An arterial line is standard. Quantitative neuromuscular blockade monitoring is standard. And for high-risk or very long cases, depth of anesthesia monitoring and central access are crucial additions to your plan.
All right, finally, let's pull all of this together. Let's synthesize everything we've talked about into a set of strategic pillars that really define excellence in anesthesia for robotic surgery. This is all about integrating best practices to actively improve our patient outcomes.
Remember those enhanced recovery after surgery principles we touched on? They are not just add-ons. They are integral to our entire perioperative plan. From preoperative carbohydrate loading to robust multimodal analgesia using those regional techniques we talked about, our goal is to mitigate the surgical stress response. And that point on judicious fluid management is especially critical here, to avoid worsening the facial and airway edema that can happen with long cases in Trendelenburg. These strategies are proven time and again to shorten hospital stays and improve patient recovery. I love this quote because it perfectly captures the essence of our role in the modern robotic OR. The surgeon's focus is intensely magnified on a 3-dimensional screen, but our focus has to remain on the whole patient, constantly interpreting the data from our monitors and guarding their physiology against every single surgical manipulation. So, when you walk away from this today, I want you to remember these 3 pillars of safety. First, vigilant, invasive hemodynamic monitoring to manage that physiological storm. Second, precise and deep neuromuscular blockade to guarantee patient immobility, which is the bedrock of safety. And third, a protective, low-pressure ventilation strategy to shield the patient's vital organs from harm. Mastering these 3 pillars ensures that the incredible technological benefits of robotic surgery are not undone by avoidable physiological complications. And that leaves us with one final thought to ponder. Robotic surgery isn't a static field. It is constantly evolving. As these systems become smarter and gain more capabilities, maybe even some level of autonomy, Our role as the human expert in the room, the vigilant guardian of the patient's physiology, will become more important and more critical than ever before. Thank you so much for joining this explainer.